Okay, so when I stopped yesterday, we were talking about um, blood pressure and what each value means. What part of the cycle is it monitoring? The other thing that you guys, you can do this on an awake patient. You can do this while they're anesthetized. I often say you should assess the strength of their pulse when they're awake, no drugs on board. Oops. Um, so you should always have their, so you can kind of get an idea of where they're starting, as far as pulse quality. Obviously, pulse quality and strength, how strong is the pulse, is going to change as they're anesthetized because the cardiovascular is depressed. But, that way you can kind of get an estimation. So it's just an estimation of blood pressure. There is a theory that if you cannot feel a pulse on a patient, like you don't feel an adequate pulse, then the mean pressure is probably below 60. So it takes at least a blood pressure, a mean of 60, to be able to palpate a peripheral pulse. Um, but the problem is, it is a little bit subjective. Like maybe your hands aren't as sensitive as mine. Maybe your hands are cold. Where are you touching? It does take a little bit of practice, but you do want to, one artery that we don't talk about a lot is the lingual artery. When an animal is asleep, they're laying on their back and their tongue is sticking out. There is an artery, the lingual artery runs right near the vein. When you look at a dog under their tongue, you can see the vein. And then right below that, you can palpate and the artery runs underneath. So you can feel a lingual artery. And I use that one a lot during surgery if I'm, concerned and I want to palpate, because it's hard when they're draped to get your hand under the table and feel the femoral artery. Sometimes you can feel the carpal artery, which is near the accessory pad, but sometimes that one's a little bit harder to feel. So the dorsal pedal is so right near the hock at the bend on the back leg. If you feel on top of the metatarsals, right near the hock, medial, and you can do this at home with your animals sleeping, you can feel the dorsal pedal artery. So sometimes I'll use that one when they're like in the prep room and I want to feel. Now you can also, the femoral, the carotid is very hard to feel because it's deeper in the neck. So that one's not, even though it's listed here, it's not an easy one to feel for a pulse rate. And then if you're in exotics, you can use the oral artery, AURAL, which is the one in their ear, and that's also good for swine. If you want to go into exotics, you work with pot-bellied pigs, that would be a good one to use. Now, there are facial arteries that are used in large animal. In the horse, they have one that runs under their eye called the transverse facial. They also have a mandibular artery, because you're not going to feel a femoral artery on a horse. I mean, they're back there. It's just not. You're really in, like when you work with cattle and horses, you're going to use their facial arteries if you need to feel a pulse. So that's something that you can check. The other thing, and I'll talk about this a little more when I do horses, but they do have the direct blood pressure is the most accurate way, but this has to be a catheter in an artery. Now, in horses, they will put a catheter in the facial, either the mandibular. In dogs, and you can even, I've put them in cats before, it's a little difficult, but we use the dorsal pedal artery for those catheters. But this will give you a continuous blood pressure reading. You'll get systolic, diastolic mean. You also get a tracing on the monitor. And that gives you the most direct. But again, that's usually used in research, equine, and then if you're doing like specialty anesthesia, you're probably not going to do it every day in practice. Indirect is the most common way, and this is considered non-invasive. Okay, so think about it. If you do a cuff or a Doppler, you're placing it outside the animal to get an estimation. So it's called indirect blood pressure. So if I ask you what are methods of indirect blood pressure measurement, you could tell me a cuff, which is oscillometric measurement. And then the Doppler is a crystal that is put over an artery, and then you can get a systolic blood pressure. Now, a Doppler, I really like Dopplers in like pediatric patients, and I like them in cats, because sometimes when you have smaller patients, the blood pressure cuff tends to be a little inaccurate, and a Doppler is going to be a little more, it's going to give you a little more accuracy. I'm going to try and find a video that I can post on your page. If you use a Doppler, you have to use something called a sphygmomanometer. I don't know if you've gone to the doctor and the nurse, they blow up a cuff and then they have like a gauge, and they blow up the cuff and then they watch the gauge go down. And that's a sphygmomanometer, is that gauge. I'm going to skip over central venous pressure. This is really used, we don't use this a lot during anesthesia. We use it a lot of times on hospitalized patients if we're measuring, and that measures via a jugular catheter how much pressure is in the venous system. The only time we really do CVPs is when we're monitoring for hydration status. And so typically when we're giving fluids, if we're worried about overhydration, or if we're really worried about the blood volume of our patient. But again, when I've done CVPs in practice, I mostly do this on hospitalized patients for various conditions, not really in anesthesia monitoring. So let's move on to oxygenation. And this is a measurement of the oxygen concentration within arterial blood, because that's where the oxygen is being carried. We don't have oxygenated blood really in the venous system, it's really in the arterial system. And there's a couple different ways to do this. Now, obviously, physically, what can I do with sight? I can look at their gums. And, I always say you need to look at them before anesthesia. Were there any issues with their gum color? We want them nice, bubblegum pink, and that would indicate that they should have a normal oxygen level. Now, this is just a rough estimate, and I have told you, if you have an animal that does have like black gums, sometimes labs and chow chows will have those pigmented gums. You can look at the inside of the lip or the vulva, the prepuce, or the conjunctiva. Those are going to be your best bet. You're not going to look at their skin on their belly. You're not really going to look at their ear. Sometimes in cats and dogs, if like a cat that's white and they have those really pink paw pads, sometimes if they're have like low oxygen levels, sometimes you can see it in their paw pads, but that's not always accurate. And sometimes if they have clear nails and you can see the quick, and sometimes the quick, if they're having oxidation problems, sometimes can look a little purpley, dusky, but mucous membranes are going to be your best bet to get an idea of color. Now, what do the different colors mean? Sometimes I say they're pale, and someone says then they have low oxygen levels. If they're pale, if we're looking at, that tends to be, they've lost blood or they're anemic. So if they start to begin to look pale or white, it can also be poor perfusion. One thing I will mention, I think you guys start sedating next week, and you will be using dexdomitor. Dexdomitor is a vasoconstrictor, and when you give it, you get vasoconstriction of the capillaries, and sometimes when you look at their gums, they will look pale, but that is an effect of the drug, not that they lost blood or they're anemic. But that's why it's important for you guys to look at your patients before you give any drugs, because if they were nice and pink in that morning and you give that drug and then they're pale, it's probably because of the drug. I don't think in 20 minutes they lost blood or became anemic if they were normal 20 minutes ago. That's why it's important to get that pre-op, assessment, and then you can compare. Now, cyanosis, which does indicate oxygenation issues is when they get the purpley blue color to their gums or to their tongue. And this would indicate, now obviously if they're not breathing, they're going to be cyanotic, but it could be, you know, pulmonary disease or for some reason, oxygen deprivation. One thing that I always, you know, impress upon students is if you have an animal during anesthesia, they're getting 100% oxygen. I should have a very pink patient. If for some reason my animal during anesthesia is starting to become cyanotic, there's two aspects to that. Am I having a problem getting oxygen from the machine to the patient, or everything checks out, oxygenation's good, or oxygen's good, and then when it gets in the patient, they're not using the oxygen. So there's two aspects to, you know, because as I said, it's very abnormal during anesthesia to have a cyanotic patient. You know, they're intubated, they're on a machine, they have 100% oxygen. So if they are cyanotic during anesthesia, you know, we have to find out where is the problem. Did we run out of oxygen? Did the oxygen get shut off? All of this has happened to me before. Or everything is okay getting to the patient, and sometimes it's a perfusion issue. They're not circulating the oxygen and therefore it's not getting to where it needs to go. One thing I do not have on here is sometimes you'll get animals that have injected like brick red mucous membranes. And if they're very dark red, which is abnormal, well, they can be hypertensive or have high blood pressure. Sometimes toxemia. If I have a patient that had like a GDB, or sometimes we have a patient that had like a ruptured bowel and they're septic, a lot of times those animals have toxemia and they will be like hyperemic. Hyperemic is like that injected red color, which is not good either. You know, it should just be nice and pink. I have to talk about, to understand this, you have to talk about oxygen and how it is transported. You know, there's two components to oxygen. There is free oxygen, and it's dissolved in the plasma. So some oxygen is dissolved in the plasma. The majority of the oxygen that we monitor is the oxygen that is bound to hemoglobin. So again, when an animal inhales and oxygen diffuses from the alveoli into the blood, the majority of that is going to bind to hemoglobin. Some of that will dissolve in the plasma, but we know in order for oxygen to get to the tissues, it has to bind to hemoglobin. So that's the one that we're really going to be monitoring. And if we have an animal that has 100% oxygen level, it means that all hemoglobin is being saturated. 100% of the available hemoglobin is saturated. And that's what we're going to talk about. Now, don't worry about calculating the oxygen content. Don't worry about that right now. But let me talk about the different values that you can get. There's something called PaO2. Now, Pa is partial pressure. But my little clue here is PA, think about arterial. When you get a PaO2 value on an animal, this is measuring how much oxygen is dissolved in the plasma. And this is the highest in arterial blood. So for example, if you guys are working with horses and you do what's called a blood gas, where you draw arterial blood, that's the only way you can measure PaO2, is you would have to get an arterial sample and it would measure how much oxygen is dissolved in the plasma. So unless you're doing a blood gas, you're not going to get this value, okay? This is what is dissolved in plasma. Now, the other thing that you will look at on a sample is sometimes your SaO2. And again, this is the percentage available to hemoglobin. But again, SaO2, because there's an A there, this has to come from an arterial sample. And this is the percent of available hemoglobin, what is bound and what is unbound. But again, this is, we get this from an arterial sample. So if you see on a test SaO2 or PaO2, Sa is saturated hemoglobin, arterial. PaO2 is plasma arterial. That's kind of the way I say to remember it. How do you remember SaO2 and PaO2? PaO2, pressure in the arterial. SaO2, anytime you hear saturation, think hemoglobin. But again, you cannot get those values without getting an arterial blood sample. Now, there is partial pressure and saturation. The relationship, it's nonlinear. So as partial pressure decreases, saturation decreases, but they don't follow the same path. Let me explain this a little bit better. Okay. Let's say you have an animal that has a low hemoglobin. Okay. And sometimes animals, obviously, if they're anemic, they may have low hemoglobin. So what that means is they don't have as much hemoglobin as a normal dog. Now, they can still have 100% saturation, meaning that all of their available hemoglobin is saturated, but they don't have as much. So therefore, they're not going to achieve oxygenation. I hope that makes sense. Because what it's saying is, if they have 50 okay, I'm going to break it down real simple. If an animal had 100 red blood cells, okay, and they all had hemoglobin and they were all saturated, okay, then we have maximum saturation, and that's all the red blood cells they have. What if I have an animal that has 50 red blood cells, okay? 50 red blood cells, they could all be saturated with hemoglobin, but they have half of the red blood cells as the other dog. So do you see how that's going to affect how they oxygenate? All of the hemoglobin they have is saturated, and they could achieve 100%, but they don't have as many red blood cells. So that's why it's not, it's not always going to parallel when you're looking at hemoglobin and saturation. Now, when a patient is breathing pure oxygen during anesthesia, they're always getting 100% oxygen. Room air is 21% oxygen. So when an animal is breathing in a room, it's only 21% oxygen. So you can see we've increased that 5-fold when they're under anesthesia. We've increased available oxygen. That's why, it's really critical if they're having trouble breathing under anesthesia. They're getting 100% oxygen. Where is the problem? So the amount of dissolved oxygen will increase, but not the percent of saturation. So what that's saying is you're giving more oxygen, which will increase the amount that can dissolve in the blood, but you can't really increase the amount of binding, because that will happen naturally. So let me get to kind of the nuts and bolts about this. So when we measure partial pressure and oxygen saturation, we're measuring, partial pressure is measuring what is dissolved. Saturation is measuring what is bound. You need a blood gas analyzer. So you can't do this test without a special blood gas machine. They do make handheld machines. They make big machines for labs. At Purdue, we had a big blood gas analyzer, but we also had little portable ones we could bring in. So your pulse oximeter, which is what I'm going to stress, is what I'm going to talk about next, and that measures saturation. PaO2 and SaO2 are always going to be elevated if you have an animal under anesthesia compared to if they were just awake in like the pre-op room or something, because we're giving 100% oxygen. When you have low numbers during anesthesia, it's going to indicate a significant hypoxemia, which is telling us oxygen is not making it to the blood to get dissolved, or is not making it to get saturated, binding to hemoglobin. Now, when we have these low values, one of the main things is, if it was an awake patient, no drugs, we would give them some oxygen support. If they were under anesthesia, I would tell you to ventilate or squeeze oxygen into the animal to try and force oxygen in and see if that improves the numbers. Now, what you guys will use, and this is a super common monitor, most clinics have a pulse oximeter. Now, when you go to the doctor and they put the little thing on your finger with the red light, that's a pulse oximeter. When we have animals asleep in surgery, our big surgical monitor has a pulse oximeter. When you guys are in radiology, we have a little handheld one that you're going to put on your patient. Because I don't think when you guys are in radiology, I don't think you guys have an ECG in there. You're not going to have all of the monitors. You're probably just going to have a pulse oximeter. What this is doing, it will measure the saturation of hemoglobin. It's going to be an estimate because it's not a blood sample. What you're going to do is you're going to put it on a mucous membrane, usually the tongue. And it will also give you, I should say pulse rate and not heart rate, but it's going to also give you a pulse rate. So the nice thing is you get an oxygen saturation and you get a pulse rate that you could compare to the heart rate that you're listening to. Because remember, don't rely on this pulse rate. These can be inaccurate. These can have errors. There is an infrared light. Now let me explain what that light is doing. The light is going to shine into the mucous membrane. If the red blood cells are, bound, if the oxygen is bound to the hemoglobin, it's going to reflect the light back, and then the light will give you a percentage of saturation. What percent of red cells are saturated? Absolute normal, or a normal patient, should be greater than 95%. That's telling you the dog has at least 95% of its hemoglobin saturated with oxygen. Ideally, I really want it like 98, 99, or 100. That's a good value. If you have a number between 90 and 95%, then this patient can be hypoxemic, which is showing that the oxygen levels have dropped. Not as much of the hemoglobin is saturated, and you really need to begin to investigate. If we are less than that 90%, if you're 85 to 90%, that is considered severe hypoxemia. And we really need to investigate. If it's my absolute lowest number, it cannot be below 85%, because hopefully you're watching me right now. When pulse ox goes from 100 to like 85, it'll start to drop kind of like a slope. When it hits 85, it falls off a cliff. It doesn't continue to just go gradually. It's called the oxygen disassociation curve. And the problem is after 85%, they're going to drop very rapidly, and we're going to potentially, you get lack of oxygen to the tissues, the heart, the brain, and the lungs would be my big concern. So this is an absolute emergency. Now, you can use a pulse ox on an awake patient. Let me talk about that. Well, I'm going to come back to those numbers here in just a second. There's a couple different types of probes. There is a transmission probe, which are the ones that look like a clothespin, like they put on your finger, the ones we put on the tongue. The light only shines from one side. The other side does not have a light. When you put these on, this is really important. The light needs to shine from, like, for example, the top of the tongue where it has the papilla. The underneath of the tongue is smoother and the light penetrates better. So sometimes if you're getting a crappy reading, I will just turn around the probe and shine the light from the bottom. Or like say you put it on the lip, one side has fur, the other side is the mucous membrane. Always have the light shining from the mucous membrane, not the fur side. Sometimes that affects your reading because you only have light shining through one side. You want to try to get over non-pigmented, hairless, or very thin tissue. So the tongue, you can do the ear. If a dog has a big enough paw, we've sometimes put it in between the toe. Like sometimes if you're doing a dental, it's hard to get it on the tongue because they're moving the head, they're like flipping the animal over. So sometimes if they're doing head and neck procedures, this is why I look for like, but the vulva and the pinna, I'm sorry, the vulva and the prepuce, you can definitely do that. Those will work. The toe web. Sometimes, you know, their Achilles tendon, you know, where the hock is, and they've got that thick tendon. And sometimes on dogs, especially like a whippet or a greyhound, that skin is like paper thin. Sometimes I'll put it over that. Sometimes I put a little alcohol. If you're going to do a toe web or like an Achilles tendon, you're going to want to put some alcohol on that area because it's going to help the light shine through the tissue. So that's just a little tip. There are reflective probes, and the reflective probes, you guys might work somewhere, and these are sometimes part of a surgical monitor. The light source and the non-lighted source are right next to each other, but this is usually hollow organs, like an esophagus or the rectum. So that's the other thing, like during anesthesia, our monitor has one. The light side has to shine up against the rectum. You don't want to put it facing down. Or if you slide it in the esophagus, the light is shining against the esophagus. Now, one big thing, obviously, if you put it in the rectum and you get a really crummy reading, is it just in a bunch of feces? Sometimes you pull it out and so sometimes you have to clean it off and put it back and wait to get a good reading. Here's the one on the tongue. So if you look at this monitor right now, the light would shine underneath. This is the clothespin. The number right here, the 97, that is the percent saturation. So that's normal, 97%. The 70, he has a little heart here, that is the pulse rate. And one troubleshooting tip, sometimes this number is not what I like. Say it was like 92%. Is the pulse rate matching the animal's pulse or my heart rate that I'm listening to? If the pulse oximeter is picking up an accurate pulse, I tend to believe the reading more. It's kind of a way to because sometimes I'll get a crummy percentage and I get a crummy heart rate. And I'm like, it's not matching. So if the heart rate's not matching, how do I trust that it's getting me a good oxygenation? You know, again, this is just an estimator. It's not perfect. But, you know, it does have to be investigated. Here are some, so here's one on the ear. Here's one they have kind of on that hock area in between the toes. So in this picture, it just shows you this green one. Well, I'm sorry. This green one is going in. They're going to put it in the rectum. But if you put it back here, you can put it over the hock in between the toes. So these are other good places. What do you do if your reading's low? Let me, hang on. Let me see if I can get to, and I'm going to post this to your, I should make you guys do this from scratch. Where is my, hang on, I'm trying to find, there we go. Okay. Okay. Okay, what I did is I made this kind of troubleshooting chart, and really everybody should, I'd say you should have done it. I put on your pulse oximeter, tongue probe. I put the normal values here. Okay, so what are the normal values? Sometimes I ask students, I go, what is a low pulse ox? And sometimes people put 90, which that is low, but your absolute value, 85% is the lowest you want it. I mean, you don't even want that, but that's the lowest it really should go. Here's just my little drawing of like, whoop, we fall off this cliff. That's that oxygen curve. But how do we troubleshoot the readings? Because you can get inaccurate readings. I think a funny story, and this was before I went to the Purdue. I was an on-the-job trained tech in a general practice. I was helping in surgery, and like I got a 90% pulse ox, and I'm like, oh my gosh, doc, his pulse ox is 90%. Oh, I'm getting worried, and I was kind of freaking out. And my boss looks over and he goes, maybe you should pick up the probe off the floor. And I look, and the probe, I was just looking at the monitor. The probe had fallen off the tongue. And I was like, oh, maybe I should have checked that before I like freaked out or freaked you out. And so sometimes these clips, they'll just kind of start, especially like little cat tongues, they'll just start to kind of slide off the tongue. So I break down the common issues. So first of all, if I get like 90%, 92%, that's below normal. Is it a probe issue? Okay. Did it fall off? Is the tongue dry? You know, their tongue is hanging out of their mouth, and sometimes it's just dry. In surgery, in the OR, we keep a little bottle of distilled water, just a little squirt bottle. So sometimes during surgery, I'll just squirt some water on the tongue. I'll take off the probe and put it back on, and sometimes that will fix the reading. Is it in the rectum? Is there feces on it? Pull out the probe, clean it, put it back in. The other thing is that I don't have written on here, is the probe dirty? Sometimes, you know, not a lot of people wipe it off in between patients, and they really should. Usually at the end of a procedure, I take a little alcohol swab and I clean the surface of the probe. So sometimes during surgery, you know, the dog was on a towel. I just squirted some alcohol on the towel. I wiped off the probe and I put it back, fixed the reading. So sometimes it's a dirty probe. Sometimes it fell off. Sometimes the tongue is dry. Sometimes there's feces. The main thing here is I'll moisten the area, and I'll also move the probe. Sometimes if it's in one spot and it's constantly clamping one spot, it'll blanch out the area and you won't get an accurate reading. So sometimes what I do is I'll take it off and move it to the lip or move it to the other side of the tongue. Basically, if I move it, clean it, moisten, and I do this a couple times, and then all of a sudden I get the same reading, I'm like, okay, I've cleaned my probe, I've moved it, I've moistened the area, I'm still getting 90. What is other things I can check? The next thing you want to check is your equipment or your oxygen source. First of all, is your oxygen on? The OR tanks that you guys will use are little tanks. They're called E-tanks. And Dr. Ritz likes to use them till they're almost, till they're pretty much empty. But I had this happen. I had a dog like gasping for air at Purdue and looked over and the bag was flat. The dog wasn't breathing. The oxygen tank had run out. The student didn't look at the oxygen and the flow meter was completely off. So we had to put on a new tank and turn on oxygen. I mean, and that's why they couldn't breathe. They didn't have any oxygen. So do you have oxygen on? Do you have oxygen flowing?
I have a question then.
Yes.
On these oxygen tanks, I'm guessing there's a gauge that tells you how full or how much is in there.
Mm-hmm.
And then what typically, is there like an average amount that you use during surgery?
There's not. So you usually set your flow meter on your oxygen at like a liter. And then you have a gauge on top of your tank and it'll say like, we use PSI. So a tank that has 500 PSI is considered pretty low. And that gauge, as long as your flow meter is on, that's where you turn on oxygen to your patient. If you have oxygen flowing, sometimes those gauges, it look like the tank, it's kind of like you running on E. Like if you look at your gas tank, it's literally on the E, but you're still driving. It says you got like 20 miles and you're like, but it's on the E, but you're still driving. So sometimes we push it till we get, I don't want to buy gas yet. It's kind of, sometimes those tanks will look like they're almost out, but oxygen is still flowing. So yeah, you'll have to look at the oxygen gauge, mainly as long as your flow meter's on. And then your machines in surgery, they have a backup tank. So if the oxygen ran out, you would turn off that tank and you would just turn on the secondary tank. The problem that happened at Purdue was whoever used the gurney last didn't change the backup tank. So when I went to turn on the backup tank, it was empty. I mean, I was pissed because it had a full sign on it. And the person never changed the tag and never changed the tank. So I had to like run and get another tank, put it on. You guys wouldn't be in that scenario because part of the thing you check is you always have one tank that you're using and the backup tank should always be full. So I hope that answers your question. But you can, for a moment, run out of oxygen. Like it can, run out, and then you just, normally like the days that I've been helping in surgery, we had one day where the tank was like below 500. And I just explained to the student, I'm like, okay, watch your flow meter. We'll look at the gauge. I'm in here with you. As long as your oxygen is flowing in the flow meter, you have enough oxygen. So, okay, so do you have oxygen? But also, these animals are going to have an endotracheal tube in their trachea, and that's delivering the oxygen. Sometimes the tubes become kinked, especially when people are doing dentals. They bend the head, they twist the head. Sometimes I look over and the tube is bent in half and they can't breathe. They're not getting oxygen. Is the machine hooked up properly? So sometimes if you switch your breathing tubes, your patient can't get oxygen if you hook them up backwards. Now, in surgery, you guys have to check your machines. Your instructor would go in and check your machine before you put the patient on. So we would find out if it was backwards before you hook up the patient. But not everybody does that in practice. So you should check your machine, run it through a test before you put the patient on so you don't get that error. There could be also a mucus plug. Sometimes in the tube, if an animal, cats sometimes produce a lot of saliva, and when you go to intubate them, you can drag down a clump of saliva, and that can cause a blockage. I've had to intubate animals in the middle of surgery, pull out a tube and put in a new tube because they became obstructed. It doesn't happen a lot, but if an animal had an obstructed tube, how would I know that? How would I know if their tube was completely blocked?
There wouldn't be a flow.
And how do you know there wouldn't be a flow? What are you watching that would indicate there's no flow?
The flow meter.
Well, you got flow meter for your oxygen, but and what about their chest moving?
Oh, okay.
They'd probably, if you couldn't breathe, you'd probably be like, gasping, and there would not be a good flow. I'll explain. And I know I don't really care if people don't like my stories, whatever. This one makes good sense. I had 2 students doing anesthesia and radiology when I was at Purdue, 2 vet students. The one was yelling for me. It was a big black lab, and it was getting anesthetized skull rads. And I go in there, and the dog is like gasping for air, using all of its abdomen, blue as blue. And I look over at the machine, and the rebreathing bag is like ready to pop. So this dog can't get air. The dog is gasping for air. I thought something was wrong with the machine because the bag was filling. Right away, the fastest thing I could do is I disconnected the patient from the machine because I thought something got clogged in the machine. Well, when I disconnected the patient still could not breathe. So right away, I'm like, it's not a machine problem, it's a patient problem. So I thought maybe the tube was blocked with something because the dog is still gasping for air and it's blue. So I have to get that tube out. So I went to, there's a cuff that we inflate so there's no leakage. I went to deflate the cuff so I could pull the endotracheal tube. When I went to deflate, it shot my syringe across the room. And the dog went, and I was like, okay. And I hooked the patient back up to the machine, got pink, started breathing. So I asked the student, I said, well, I was going in between rooms. So I was like, what happened when I wasn't in here? Well, when she was filling up the cuff, she kept she thought she heard a leak. So she kept feeling that this cuff puts pressure. So if you have a trachea and you put a tube in the trachea, it's not always a perfect size. There's a little air cuff that you fill so that you don't get leakage of gas. And it's a little air bubble, but the trachea doesn't stretch. Well, she kept filling this air bubble, and my other instructors, we all kind of put our brains together, think that she put like 10 syringefuls, 12 mil syringefuls, and we think it kinked the tube on the inside. So the dog literally couldn't breathe. But the fastest way I discovered that is I walked in, I'm like, he was abdominal breathing, gasping. He was blue, and the bag was huge. And when I couldn't even squeeze it. And so the fastest thing I did, and I hope you remember this because if you're ever in this situation, I disconnected his breathing tubes from his endo, and that took him off the machine. Now, if he started breathing better when I did that, then I have a problem with my machine. Maybe there was like, maybe something got blocked. I thought sometimes those pop-off valves, you guys will close a valve to give them a breath. Sometimes they get stuck and you can't, that'll explode their chest. So there's like a lot of troubleshooting, but the fastest thing I did was disconnect. And then I could discover where is the problem. But if an animal can't breathe through their tube, those are some things that they're going to show you. There's maybe going to be abdominal effort, a change in color, and then you have to kind of troubleshoot. And then if your tube goes too far down the trachea, if you guys remember, the trachea splits into two sides at the bifurcation. The end of your endotracheal tube is supposed to be here so that oxygen gets to both sides. Sometimes people do it the wrong way and they put the tube all the way in, no matter how long it is. If your tube goes down to only one side of the lungs, how is oxygen getting to this side? And that patient can, sometimes if they're not oxygenating half of their lungs, I always check my tube placement, make sure the tube didn't get pushed down too far. If you do all of that, you've moved your probes, you have oxygen, and Sean, if I haven't said this or for everybody, one thing to check the flow is I can disconnect and I put my hand in front of their breathing tube, and if they're breathing, do I feel air? Because if there was a blockage, I would put my hand here and they would be breathing and I would feel no air. So you can check flow, not your flow meter, but I would check, are they moving air through their tube? If they're doing that, the last thing you can look at, is it a patient issue? Meaning my oxygen is getting into my patient adequately, but what's happening when the oxygen goes in the patient? Because then they have to move it where it's supposed to go. Do they have pulmonary edema or pneumonia? Do they have constrictive pulmonary disease where their lungs don't expand? I did anesthesia, helped neurology, and it was an old Westie getting back surgery. And they were having trouble with CO2 and oxygen levels. And I had to turn up the ventilator. And then the doctor said, well, yeah, his lungs look a little scarred and a little older on x-ray. And I'm like, oh, that would have been nice to know. Meaning his lungs were stiff. And so they're not gonna, he wasn't ventilating by himself well. We had to increase ventilation and kind of shove the oxygen in. So that's a constrictive issue. That's a pulmonary issue. Or they have a pulmonary embolism. If you had a dog with heartworm and then you had a chunk of heartworms fall off and lodge in the vessels of the lungs, the problem is the oxygen is getting to the lungs, but there's no blood flow to that lung. Does that make sense? Then the oxygen can't diffuse because there's no blood flow. So, when you get to letter C, the thing is, as a tech, I can troubleshoot A and B pretty much myself. If I've checked everything, I'm always communicating with my doctor. I don't want you guys to think you're doing this by yourself. I might be like, hey, Dr. Paul, I've checked this and this and this and this. Maybe we need to do x-rays after surgery. Maybe we need to stop surgery. But the big thing here is there's a yellow note here. Does increased ventilation improve your reading? So that Westie I talked about, had a low SpO2. By me turning up the ventilator, increasing ventilation pressure, the oxygenation went up. The dog just needed more pressure and more help. So as for students, I'm like, increase ventilation, increase pressure. Does that fix your problem? And then if not, you have to look at VQ mismatch, which is ventilation to perfusion. And then that's usually like a blood flow in the lung issue and may need more testing after surgery. The big thing here, guys, is I know this looks like a lot. You can accomplish this in less than like 2 minutes. I can move the probe. I can give my patient a breath. I can check my flow. I mean, I can do all this very quickly. And the other thing is I want you guys to know is on a test, I'm giving you a tip. If I ask, how do I fix oxygenation? Do not tell me to turn up the oxygen. If you have an animal not breathing and you turn up the oxygen level, it's not going to magically fix the problem. They're not breathing. The oxygen has to get into the lungs, but the lungs have to expand. If they're not breathing, they're not pulling in the oxygen to the tissues. So my thing is that, students on tests want to tell me how to fix every problem is give more oxygen. It could be blood pressure. It could be depth. I'm like, yes, sometimes you have to turn up the oxygen, but in this issue, you have to increase. If you say turn up oxygen and ventilate your patient, that's a good answer. You can turn up your oxygen and squeeze it in. And sometimes by squeezing it and force, especially in an animal that's not breathing or not breathing well. So I am going to post this picture. I did have some students that are in surgery now. They printed this little sheet and they put it on their clipboard because, you guys will make a cheat sheet for surgery, like a monitoring cheat sheet. You do that in surgical nursing. But this is a good little handout to keep. It's just a good little troubleshooting. What do I do? Don't be like me and panic at the first bad reading. So,